Mohammed. Ibrahim.
Sorry, please unmute now. I had stopped everyone from unmuting.
Okay. Ibrahim, can you unmute?
Yes.
Okay, bro. Open for us.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Amen. So today we are going to have our second series of the Msaun KNH Grand Round. And tonight we're going to have the fifth years who represented by Omar Dubat. He's going to present an obstetric and gynecology case, pre-eclampsia. The discussant will be Dr. Ajabo. So Omar, you can begin.
Thank you so much, Abdi. I think I'm loud and clear. So today our case is pre-eclampsia. The patient's name is GWM, a 38-year-old female at Ward 1A, admitted on 23rd March 2022, who resides in Donholm, works as a primary school teacher. Our patient is para 000 gravida 4. Her last LMP was 4th July 2021. Her expected date of delivery is 11th April 2022. Her gestation by date is 38 weeks. The chief complaint patient presented with persistent headache for 2 days and lower limb swelling for 2 days. Yeah. On the HPI, patient was well until 3 days prior to the admission when she presented at clinic 18 with complaints of persistent headache for 2 days. That was global in nature for the first day, but the subsequent days it has lateralized to the right side. The pain was not relieved by analgesic or sleep. There was no associated convulsion, no associated nausea and vomiting, no blurring of vision, and no abdominal pain. Patient also complained of lower limb swelling up to the knees. It was gradual on onset and it was non-peaking in nature, but there was no associated facial puffiness and no difficulty in breathing, no cough, no paroxysmal nocturnal dyspnea. Patient reports to have 4 other ANC visits, in which her blood pressure was normal, except her last visit, which is the current one, when her PP was 156/92 millimeter Hg. She reports to have no history of hypertension in previous pregnancy. Patient reports to have she reports to have no vaginal discharge or bleeding. On antenatal history, she reports to have attended 5 ANC visits. She has started when she was at 20 weight gestation for this pregnancy. Her last visit ANC profile, her HP was 11.2 grams. Her blood group is B positive. HIV and VDRL were not reactive. Her past ops history, she had her first delivery in 2010. It was spontaneous vaginal delivery in hospital. The outcome was 3.6 kgs at 39 weeks. The outcome was a live male infant, but after the baby died 3 weeks due to acute respiratory distress, 3 weeks after the delivery. Her second delivery was 2012. It was still spontaneous vaginal delivery in hospital, 2.4 kg, 42 weeks, that is postpartum. The outcome was a live male infant. This is the one she reports to have like induced labor. She has induced labor because of the labor postpartum. In 2016, she had a spontaneous vaginal labor in hospital again, 3.2 kg, the outcome, 39 weeks. Outcome was a live female infant. Patient reports to have all her previous deliveries in a breech presentation, but all of it she has delivered in spontaneous vaginal delivery. None of it had a CS delivery. Her gyne history, the age of menarche is 15 years. The cycle length is 28 days. The duration of her cycle is 5 to 7 days, and the flow of the cycle is heavy in the first 2 days, which uses up to four pads, which are fully soaked but reduced in subsequent days. She reports to have no dysmenorrhea and no dyspareunia. She has never done pap smear or have taken HPV vaccine. On a family planning, she uses combined oral contraceptives, but in 2016, she reports to have tried an implant, Jadel, and had a side effect such as weight gain and elevated blood pressure. So she went back to her combined oral contraceptive use. Past medical history had one previous admission at the age of 16 years old due to a severe anemia as a result of the heavy menses, in which 2 liters of blood was transfused. He has no history of hypertension, diabetes, or any other chronic condition, no history of previous surgery. Her family social history, she is married and works as a teacher. There's no history of smoking and alcohol intake. She has a positive family history of hypertension in her family. That is, her mom is a hypertensive patient. Her father died as a result of lung cancer. On review of system, after the inquiry, there was no history suggested for other system infection. In summary, a GWM, a 38-year-old female, para3+0, gravida 4, at 38 weeks gestation, presented with 2 days history of persistent headache and lower limb swelling with an elevated blood pressure of 156/92. On examination, she is in a fair general condition, lying supine in bed, not in an obvious respiratory distress. The vitals were BP of 127/76, pulse of 88, respiratory rate of 16, a temperature of 36.7 degrees. Her abdomen was distended, moves with respiration, and there was obviously a linea nigra and strata gravidarum as a result of the pregnancy, the gravid uterus. The fundal height was at 38 weeks. By examination, the lie was longitudinal, presentation was cephalic, and fetal heart rate was 1.2 beats per minute. There was no positive finding on other systems examination. Investigation that was done, urinalysis has been done. The results, urine dipsticks has showed a proteinuria of 1+ and leukocytes of 2+. Full hemogram was done, HB of 13.6, white blood cells of 9.3, which is within the normal range, and a platelet of 287. UECs and LFTs are done, both are within the normal parameters. Also, obstetric scan was requested, and the result was as follows. The gestation by age as per the ultrasound was 36 weeks. Estimated fetal weight was 2,954 grams. Biophysical profile was 9/10. Among the parameters of the biophysical profile, the one which was reduced was amniotic fluid, which was 1/2. There are 5 people is ranked on 2, maximum and minimum of 0. So the one which has reduced to make it 9/10 was the amniotic fluid volume. Expected date of delivery as per the scan was 21st April 2022. Fetal heart rate was 140 beats per minute. On conclusion, from the ultrasound scan, a single intrauterine pregnancy at 36 weeks with fetus in a breech presentation and associated oligohydramnions. That is as per the report of the scan. On diagnosis, GWM, 38-year-old female, 3+0, gravida 4 at 38 weeks gestation, presented with 2 days history of persistent headache and lower limb swelling, elevated blood pressure of 156/92 mmHg with a positive proteinuria of 1+ in a urine dipstick and a possible diagnosis of preeclampsia without severe features. Currently, she is on management of dexamethasone 6 grams IM BD for 2 days, methyl dopa aldomet 500 milligram paus for 1 week, nifedipine 10 milligram, and paracetamol 1 gram TDS. That is the end of the case. Yeah.
Okay, I think, bro, you can continue to the presentation unless anyone has a question up until there.
Let me give the doc any chance. Dr. Ajabo, anything to comment on it, or we proceed to the Is the doc within the meeting?
I can see she's here and her mic is on as well.
Guys,
Hello, Doc. Yes, we
Hi,
can
Doc.
hear you now.
I've been speaking all this time. So I'm saying the presentation was well done. I saw somebody with a question about the mode of delivery. It is not in our scope of discussion today. It's neither here nor there. It's just based on history. So whether the patient had a vaginal delivery and not cesarean delivery, we are okay with that presentation. So we can move forward, not unless anybody else has a question.
I think I can move. You can see my screen?
Yeah, we can see it.
Thank you. So, on the background of the case discussion, the topic we are dealing with is hypertensive disorders in pregnancy. Hypertension definition is an elevated blood pressure of more than or equals to 140/90 millimeter Hg measured at 2 times at least in 6 hours interval. There are terms we use for a classification of hypertension in terms of pregnancy. We have gestational hypertension, pre-eclampsia, eclampsia, and a chronic hypertension. When we say a gestational hypertension is an elevated blood pressure more than or equals to 140/90 after 20 weeks of gestation without proteinuria. That is the definition of a gestational hypertension. That is a hypertension that has come with as a result of the pregnancy, but there is no proteinuria. And when we say a preeclampsia, we'll see the next definition. Preeclampsia is a multi-system disorder of unknown etiology characterized by the development of hypertension of an extent of more than 40/90 and or proteinuria after 20 weeks of gestation in a previously normotensive and non-proteinuric women. So the differences in between a gestational hypertension and a preeclampsia is the aspect of proteinuria. In preeclampsia, there is a proteinuria, but in gestational hypertension, there is no proteinuria. And both of them, they must be diagnosed after 20 weeks of gestation. Eclampsia is a complication of preeclampsia, whereby it is an eclampsia. Eclampsia is a complicated form of preeclampsia where there is a seizures or convulsions that are there, and a chronic hypertension is an hypertension that was there before the pregnancy and occurs even after the delivery for 2 to 3 weeks. So our case today is preeclampsia. That's the definition. A BP of 140/90 with proteinuria diagnosed after 20 weeks in a normotensive and proteinuric woman. What is the pathophysiology of the preeclampsia? A preeclampsia, most books, they give the basic pathophysiology as 2 things: vasospasm and endothelial injury. The vasospasm that has resulted the preeclampsia is as a result of 2, which is an imbalance from the vasodilators and the vasoconstrictors. The vasodilators that is say prostaglandin I2 and nitric oxide, and the vasoconstrictors that is there is angiotensin 2 and trophoxin A2. So when there is imbalance in between the vasodilators and the vasoconstrictors, that will result a vasospasm, and that vasospasm will result from endothelial injuries, which is due to an oxidative stress. And inflammatory.
Some people are feeling like you're very fast. Can you go slower?
Okay. So I'm saying there are 2 mechanisms that is there: the vasospasm and endothelial dysfunction. The vasospasm is a result of 2, a vasodilator and a vasoconstrictor imbalances, and those are the 2 things that are there. For endothelial dysfunction, there is as a result of oxidative stress and inflammatory mediators. So the inflammatory mediators that is there, that as a result of it, is cytokine and tumor necrosis factor alpha and interleukin 6. So when you have an imbalance in between the vasospasm and the endothelial dysfunction, will result to preeclampsia. What are the risk factors for preeclampsia? Number 1, a prime gravida. I know we have some 3 years, 4 years, 6 years, and also the senior 6 years. Yeah? when we say a primee is a woman who is having her first time pregnancy. So the reason as to why we have the preeclampsia in high risk factor for the primigravidas is due to the first exposure to a chronic villi. So it can be that first exposure to chronic villi is will result to preeclampsia. Two, if a woman has first pregnancy to a new partner, for example, she had first and second kids, and then she has changed the partner, so there is a high risk for developing a preeclampsia in this new partner, but it is her third case, third child, I mean. The third risk factor is family history. If the mother had a preeclampsia before, there is a high chance that the mother, the siblings can be a factor for a person to develop, a lady to develop a preeclampsia. The fourth risk factor, we have a pre-gestational diabetes, which is also a factor for preeclampsia, multiple gestations, renal disease, and antiphospholipid syndrome can also be a factor. The other factor that can cause is age, which is more than 40, and obesity is cancer. So this can be some of the factors that lead to a person to develop a preeclampsia that we talked about the definition. What are the signs and symptoms of preeclampsia? Number one, we have an elevated blood pressure that we have seen a BP of more than 140/90 millimeter Hg, and a proteinuria diagnosed after 20 weeks of gestation. That is one. Two, we have a visual complaints. There is aspect of a blurring of visions that comes with the preeclampsia. So patient will complain of visual complaint. There's also a persistent headache, that the one our patient has now. I had a persistent headache. There's also an aspect of abdominal or epigastric pain that the patient complain about, and this is as a result of they talk about the aspect of liver capsule hematoma that result to development of abdominal pain or epigastric pain. There's also an aspect of swelling of the face and the hands and legs. There's aspect of nausea and vomiting, and there's also an aspect of edema. So these are the symptoms you may expect a patient with preeclampsia to present with. What are the criteria for severe preeclampsia? There is two types of preeclampsia. We can see preeclampsia with severe features or preeclampsia with severe features. So what are the features that a person can say this patient has a preeclampsia with severe features? One, the PP of more than or equals to 160/110. That is, and for you to diagnose a preeclampsia, we say the PP of more than 140/90. So you see, we are moved from 140 to 160 for the systolic, and the diastolic of 90 to 110. So whenever the patient has a reading of 160/90 and above, that's you're dealing with severe preeclampsia. Two, a proteinuria of more than or equals to 3 grams in 24 hours urine collection or a test strip can give you also a preeclampsia with more than 3 grams and give you a severe preeclampsia. Two, the third thing is a thrombocytopenia of less than or equals to 150. Some books call it around 100, but that is the range they usually give. The fourth things, we have an elevated liver enzyme. When the patient has been done for LFTs and you have elevated ALT and AST, there is high chances of, again, classifying that patient as a patient with severe preeclampsia. Persistent headache and visual disturbances is also another criteria. Epigastric pain and oliguria of less than 400 mils in 24 hours can also give you. And then can also lead to oligohydramnions. When the patient is oligohydramnious, when one of these features are there, that's the time you can classify the patient with severe preeclampsia. So this is the criteria for severe preeclampsia. What are the investigations that have been done for patients with preeclampsia? Number one, you will do a full hemogram. In the full hemogram, what you're interested in is the HB and the platelet level. For the HB, you are going to decide whether the patient has anemia. And if it is the anemia, you will check the MCV and the MCH to check which type of anemia that the patient has. And then also for thrombocytopenia, you will check the platelet to diagnose the thrombocytopenia, because when you have a platelet count of less than 150/100, so the patient is classified to another system. For example, severe preeclampsia with severe features. Or there is also another syndrome that is related to preeclampsia, what you call the health syndrome, where we have the The H for hemolysis, E for elevated liver enzymes, and low platelets. So that thrombocytopenia, when you do the full hemogram, the low platelet counts will give you an idea if you are moving also towards the health syndrome. Another basic test that is usually been done is urinalysis. In the urinalysis, you are interested with whether the patient is passing protein in the urine. That's what we call it proteinuria. So a +1, +2, +3, an aspect of it will guide you whether the patient has. So a proteinuria is one of the diagnoses for preeclampsia. In case, for example, our patient also having a leukocyte a bit, so you may also have another diagnosis. The doc will guide us based on that one. Mostly they talk about the UTI aspect. The UECs, which is the kidney functions, may be elevated. In LFTs, liver function test, we have elevated ALT and AST. So that those two elevated liver enzymes can lead you for severe preeclampsia. Another test that can be done apart from the four you have mentioned is antenatal fetal monitoring. That's where we can do the daily fetal movement count. We can do the op scan, and we can do cardiotocography, CTG, that is usually being done also. Because the first four tests, you are dealing with the mother, the status of the mother. And then the fourth final test, after now you have stabilized the mother, you just check the child, the fetus inside it, to check for the status of the fetus. Management, how do we manage a patient with preeclampsia? It is based on the case. The first thing that you usually do is that if the patient is not in severe, you start with the bed rest. And when the patient is put on a bed rest, there is a procedure that they usually do that the patient should lie on in a left lateral decubitus position. What is the purpose of it? Because when the patient lies on the left side in a lateral decubitus position, that will augment uteroplacental blood flow. When you have an increased uteroplacental blood flow, meaning that the fetus is getting enough blood. And when the fetus gets enough blood, so you see the blood pressure will go down. But the definitive management for preeclampsia is delivery, regardless of in case the mother is in severe features, her life is in danger. That is the absolute thing that you're going to do, delivery, regardless of the mode of delivery, whether you do as SVD or whether you do CSCS. The medication we use, so we start the PEEP medications, when our blood pressure goal should be less than 140/90. That's the diagnosis we give. The recommended drugs that we use, because the mother is pregnant, we don't use each and every drug that's available. We have a drug that we use for a pregnant mother, which is safe. Number one is methyl dopter, in which our patient was on already with this drug, methyl dopter. The brand name they usually use is the Aldomet. We have Labetalol and the Fidipine. Those are the three common drugs we usually use. Hydralazine also sometimes we use based on the patient's BP level. There are some drugs, antihypertensive drugs that are contraindicated in pregnancy. These are two groups of drugs. So we have angiotensin converting enzymes inhibitors and angiotensin 2 receptor blockers. An example of angiotensin 2 ACE inhibitors is the one that the group usually call it the enalapril, captopril, those groups. So you don't tie those in pregnancy. And also the ARBs, which is the angiotensin 2 receptor blockers. The group we usually call the Saturn group, the losartan. So these two groups you don't tie in pregnancy. The reason as to why you don't do is that because they can aggravate uterine ischemia. When you cause a uterine ischemia, that can result in renal dysfunction to the fetus. So those two are contraindicated in pregnancy. But the other three that were mentioned, we use it. The other drugs we use given to a preeclamptic mother include magnesium sulfate. The purpose of magnesium sulfate is as a prophylaxis to eclampsia. Magnesium sulfate is a neurostabilizer and also muscle relaxant. It's also anticonvulsant. So a patient with preeclampsia at times happens that the patient proceeds to eclampsia. So you give the magnesium sulfate as a prophylaxis to prevent the patient to proceed to eclampsia, which is the hypertension together with proteinuria, patient now added with convulsions. We also give those patients with dexamethasone. The purpose of the dexamethasone is a corticosteroid. The purpose of the dexamethasone, dexamethasone is usually given to enhance the fetal lung maturity in case, because you expect when we say that the definitive management of preeclampsia is delivery. So maybe the patient, the mother is at in between 28 weeks, 29 weeks, or less than 34 weeks. So you give the dexamethasone to enhance the fetal lung maturity of the fetus, so that by the time that child is being delivered, the child will not develop a respiratory or complications related to breathing issues. So they usually give this one for fetal lung maturity. So they give this dexamethasone IM 6 milligram morning and then the evening for 2 days, and then from there the patient will plan for delivery either for induction or for CS, regarding the patient's status. What are the features for screening? Because it is one of the leading mortality, maternal mortality in the whole world is preeclampsia. So what test can you able to do, or can give you a screening, an idea whether there is an impending preeclampsia? Number one, you have a Doppler ultrasound. A Doppler finding of high resistant index, RI index, in the second trimester may predict an impending preeclampsia. Two, if there is a presence of diastolic notch on an ultrasound, may also predict a preeclampsia. Although this aspect they usually call a diastolic notch will lead more of what we usually call fetal growth restriction, FGR. But it can give you an idea of an impending preeclampsia. It's also an test, they usually call it the rollover test, whereby the patient blood pressure is taken while the patient is lying on a side, and then after asked to roll on his back, on her back, and then the blood pressure is again taken while on side, while on her back. If there is a differences in the systolic, mostly the systolic of more than 20 milligram, 20 millimeter Hg, that can suggest that preeclampsia. So they usually call it more than 20 millimeter Hg, a positive rollover test, which can give you also an idea of the an impending preeclampsia. So the last thing here is we know the dangers of the preeclampsia. What are the things that we can do for high-risk patients to prevent preeclampsia? Number one is to have a regular antenatal checkups. What do the antenatal checkups do? They will check the blood pressure, because in case the blood pressure is high, it will be monitored and controlled. And then also in case of the rapid weight gain, that can give you an idea of so if you prevent those two, there's higher chances as also you reduce the chances of preeclampsia. Number two is to give a low dose aspirin, which is in between 50 to 150 milligrams for high risk patients. The purpose of the aspirin, we know that a low dose aspirin acts as a cyclooxygenase inhibitor, thromboxane. Therefore, it will reduce the production of TAX2, which is the thromboxane A2. And the thromboxane A2 is one of the vasoconstrictors. So when you reduce a vasoconstrictor, you give more chance for the vasodilators. Therefore, there is lower chances of preeclampsia, and the blood pressure will not be high. The third thing you can do is for you to give a low molecular weight heparin for those patients with thrombophilias. We have seen thrombophilias. An example of thrombophilia is we have antiphospholipid syndrome. So such patients, they usually give a low weight heparin, the one we call it the clexane. So you give across as the mother continues during her gestation trimester, so that you lower it. And the final thing, you can supplement calcium 2 grams per day to prevent preeclampsia. That is my last point. Thank you.
Okay. Thank you very much, Omar, for that presentation. I think up to now, can open the floor for maybe any questions. I would like to maybe recognize the presence of Professor Qureshi, who is senior lecturer at the University of Nairobi, and Saun KNH patron. So any questions from the audience, feel free. Okay, I can see we have some questions on the chat box. Maybe I can read them out for you, Dr. Ajabo.
Go ahead.
Okay.
I'm trying to look through for them.
So the first question, someone is asking in regard to the pathophysiology of preeclampsia. he's stating that Mustafa is saying a failure of cytotrophoblasts to invade the endovascular lining of the spiral arteries. So he's asking, does this explanation still stand, or new literature has moved to the vasodilator vasoconstrictor imbalance? Was that clear?
Yes, it's very clear. And in response to that, I'd like to say that both are possible pathogenesis for the cause of pre-eclampsia. And it's not the way he has said it. Wait. It is the invasion of the cytotrophoblast into the vascular lining of the spiral arteries and beyond. That is what part of the pathophysiology for preeclampsia, as well as now this can lead to the imbalances in the vasodilator and the vasoconstrictor factors. Usually it starts from the cytotrophoblast and the entire placenta. By the time you are getting clinical signs and symptoms of hypertension, whatever you're calling preeclampsia, these changes have already occurred, starting from the uterus, going to the system. And it's multiple factors that cause, and not just one factor. I hope that answers the question.
I think that was clear. Mustafa, maybe if that wasn't clear enough, you can send a text as well. The next question states, please qualify, maybe differentiate gestational hypertension and its difference from chronic hypertension in terms of how many weeks postpartum.
So in response to that, we say chronic hypertension is hypertension that occurs before 20 weeks of gestation, while gestational hypertension occurs after 20 weeks of gestation. The dilemma or your question should lie in differentiating between gestational hypertension and preeclampsia, in which case preeclampsia comes with the proteinuria. Sometimes it can come with the end organ damage, which to you will be deranged urea electrolytes, LFTs that are higher than usual, symptoms of health. Sometimes it's quiet and then it's eclampsia. That's how we know it's preeclampsia.
I think that was well done. The next question is, can dexamethasone aggravate the okay. So can dexamethasone aggravate the situation of the mother by increasing weight? That is Cushing syndrome.
Good question. If given over long time, yes. This is given over 2 days in a dose that is therapeutic for gland maturity. So no, it will not cause it. It will not cause Cushing syndrome.
Okay.
You should also worry about its use maybe in the diabetic patients, in which case you will do sugar monitoring if it's indicated.
Maybe I can also add a question of my own. There was this issue of proteinuria being included or excluded in the definition of preeclampsia. What do you have to say about that?
I'll say yes to that. I will also ask for Prof. Qureshi's assistance. There's a lot of literature moving away from proteinuria as part of the diagnosis of preeclampsia. If you want to strictly differentiate between preeclampsia and gestational hypertension and chronic hypertension, or preeclampsia superimposed on chronic hypertension, that is where your proteinuria becomes a trick. And what if proteinuria is not there, but BPs, if BPs are more than 160, 110 after 20 weeks of gestation, I'll treat that as preeclampsia, because with that, there's already end organ damage, or there is IUGR or fetal issues. So yes, you can use it as diagnosis, but not as a way of measuring treatment results and improvement. Most of the literature is saying that we shouldn't use it as a marker for response to treatment, but you can still use it as a diagnosis, but it's not definite diagnosis of preeclampsia. Have I answered your question?
Yes, thank you very much. We have another question here as well. In case a preeclamptic mother gives birth to a premature baby, is there a way dexamethasone or surfactant can be administered to the newborn to enhance lung maturity?
So to the newborn, we'll administer surfactant, but if we had planned prior, we'd give the dexamethasone.
Okay, yeah. Another question, in terms of management, when do you decide to deliver and when to do conservative management?
This you'll have to learn by clinical experience. It's patient to patient. It depends on how that patient presented, the gestational age, how is the end organ function, how is the fetus. So you cannot say you'll deliver at 36 or at 34. Of course, if you have a mother at 36 weeks with preeclampsia, definitely that is delivery. But below that, it's patient to patient as to how they're presenting. Sometimes even the baby is no longer your priority. To save the mother, you will deliver that baby. If the patient is responding to a treatment, organ damage is improving, there is no IUGR, you're not worried about an immediate IUFD, then you can give the mother a chance a week or two. So it's really a clinical approach.
Okay, thank you very much. Next question. In terms of management, okay, sorry, I read that. What specific signs and symptoms indicate that a patient with preeclampsia has a high risk? Hello?
I can hear you.
Okay, sorry, I thought someone was trying to speak. I'm asking what specific signs and symptoms indicate that a patient with preeclampsia has a high risk of experiencing a seizure due to CNS irritability. So I think maybe it's just asking the prodrome symptoms of preeclampsia. Yeah. Okay.
You mean eclampsia? Like how will you know who's at risk to go into eclampsia than the patient who wouldn't? So in my clinical experience, I'd say if you have a patient in the ward and you have managed those BPs well, there is unlikely chance of going into eclampsia. However, now if the patient was at home, maybe not aware of the high BPs, and they can be asymptomatic, and then they go into eclampsia. Others are on, yes, oral medication, maybe one medication, the BP is not well controlled, they're not aware, they're just having headaches, they're just tired, they can be drowsy or irritable, as you said. They can be normal at the same time, but maybe a bit tired, then they go into the eclampsia. So usually they are maybe working up their courage to go to the hospital, they're feeling this or that. There is no clear way of knowing because most of them, they present to us from home. The few eclampsias that occur while we are with them in the ward, they're usually poorly managed preeclampsias that now move on to eclampsia.
Okay, I can see we have a comment here from Dr. Bajaber, who is Secretary General of CAMP and also a pediatric registrar. So he says, I remember pathogenesis mainly through three mechanisms: the abnormal remodeling of the spiral arteries, defective trophoblast differentiation, that is defective pseudovasculogenesis, and placental hypoxia and ischemia, which are all somehow interlinked. I think, yes, that is. I stand corrected.
But he remembers it's true, yes.
Yeah.
Let's go on to the next question.
Okay, so we have one of our seniors, Ogle, is asking, in the setting of persistent high BP, that is maybe more than 200 and a diastolic of 100, after maximizing antihypertensive with HELP syndrome and organ damage, would you still go for emergency CS urgently? And will the outcome be affected by the high BP?
So the BPs are that high after maximizing, or they were that high and then we went max on the antihypertensives?
So he says the pressures were high, and after maximizing with HELLP syndrome, would you still go for emergency? Yes. And so they were high, and we maximized as well.
Okay, so we have HELLP syndrome, and then he wants to know whether the outcome will be affected by the high BPs. So how you deliver, whether by CS or by normal delivery, is dependent on several factors. The gestational age, was this woman in labor or not? But if this patient was in these BPs and you have maximized all your antihypertensives and she is otherwise stable, you have done your labs, you plan to deliver via CS, the high BPs will affect the outcome with regards to most likely poor fetal outcomes. Your maternal outcomes will not be affected as much because your anesthesia team will be aware of how to moderate those BPs so that they don't suddenly drop. I think, Ogle, you can directly ask one aspect at a time so that I can answer.
Okay. So maybe as he's typing, we have another question. How does calcium supplementation prophylaxis work in preeclampsia? I think this was also covered in the presentation.
True, it was covered in the presentation. So the exact mechanism, I'm not yet sure. Prof can help me with that. But calcium is essential for vascular revascularization or angiogenesis, so to speak. And the main pathophysiology in preeclampsia is defective vascular formation. So that's why we give it earlier on in pregnancy to aid that to prevent the sequelae of the sequelae of the vascular endothelial damage, which leads to the features we see as preeclampsia.
Okay. Thank you very much, Doc. I think at this point, we would like to maybe invite Prof to make a few comments and maybe ask any questions.
Yeah, I'm putting an extra on the things that I had missed out on.
Yes.
Prof?
Okay. Shukran.
Assalamualaikum warahmatullahi wabarakatuh. I just got notice of this grand round, I think when it was halfway over. But I was in a meeting myself earlier. I think all of you have, from the presentation, from where I heard it, and the responses that I have heard from you, Dr. Ajabo, I think you've done very well. I think I even noticed that some of you are even reaching postgraduate level with the presentation that was being made and the questions that are being answered. So I suggest it's nice to just know the very basics, but if it's good if you do go to postgraduate level at an undergraduate level. I commend you. I don't remember all the questions that were being asked, but if I start with the last one with calcium supplementation, it's known that women who are calcium deficient are at higher risk because of the reasons Dr. Ajabo explained. And it's very difficult to know who is calcium intake sufficient and who isn't. It's felt that most, if we were to start analyzing the diet, even in places where there is milk available and dairy products, we will still find women who are deficient. And that is why calcium supplementation is given for anybody who has been previously hypertensive disease. So now to prevent a future pregnancy, having hypertensive disease, we start giving it. Just also to correct something that I saw on the low dose aspirin. I think the recommendations now are to give 150 milligrams, not really the 50 to 150. So let's just stick to the 150. This question that was being asked by Dr. Abdullahi Ibrahim Ogle, with regards to, would you still go in for an emergency cesarean? So as Dr. Ajabo said, the mode of delivery will depend on very many factors. Of course, what is the gestational age? What is happening to the fetus? So if the fetus is having, a growth, is a growth restricted fetus, the Doppler flows are not fine. The umbilical artery, the middle cerebral artery, if all those things are affected, then you know that that fetus is not going to be able to withstand labor. Then you would go for a cesarean section. But if all those things are okay, this is a patient who is delivered vaginally before, you have a good Bishop score. When you start inducing, you expect a good outcome, then you would go for a possible vaginal delivery. So it'll get influenced by a lot of factors, and then eventually you have to sort of give give individualized treatment depending on all those things we've talked about. What else was there? Dexamethasone, yes, you would definitely give dexamethasone. And when you have hypertensive disease, you want to give the dexamethasone so that you improve the chances of survival of that baby. Once I think there were another question whether we would go ahead with conservative management or do aggressive management. So if you have hypertensive disease with severe features, you just need enough time to have given your steroids. You've gotten back all your results from the maternal parameters. And if she's very remote from term, you can try and bring her possibly to at least 34 weeks. But if you are already 34 weeks, then you may not have much benefit in continuing with that pregnancy. But we do have studies within our department. I think Dr. Ajabo, if you refer to Dr. Zainab's study, that's what she did. She looked at conservative versus aggressive management with hypertensive disease with severe features. I think the other thing I remember, what happened to that? Aspirin, how much earlier do you administer aspirin? So you can start aspirin from 12 weeks as a prophylaxis. If you have a patient who is at high risk, she's previously had hypertensive disease, then you can start that. Oh yeah, there was the rollover test. The rollover test really is obsolete. We don't do them. We probably, I don't know, you might have just read it in literature. We don't even hear about it these days. You have other ways of predicting, through ultrasound, which will start seeing changes very early in the fetus. So you wouldn't go in for some things like the rollover test. But the presenter looks like had gone into a lot more detail to prepare the presentation and had even come up with some things like that, which we've even forgotten. Okay, I think those were all the needed some input from me, and I've even added quite.
Thank you so much, Prof.
You're welcome.
Well done to the undergraduates. You've prepared a very, very good slide and chosen a very important very much important topic. I think you've had the opportunity to see these presentations, patients with preeclampsia presenting in different ways, and there have been many, many different outcomes despite optimum care as they approach or as they get to us in Kenyatta. So patients will always be different. There'll be no specific plan for you, like this is what I will do. No, preeclampsia will come and hit you in different ways. It will come in eclampsia state, it will come in end organ damage, it will come with IFD, it will come with a patient in coma with GCS of 3 following an eclampsia, and you may lose that patient maybe intra-op, you may lose that patient without even taking her to theater. The important thing is recognizing who is in more danger as you see them antenatally, how to balance out your antihypertensives, and then who is more at risk given a prior history, a family history, the primigravidas, keeping a good eye on them antenatally. And then once a patient has had a preeclampsia, taking the right care in the consecutive pregnancies. Thank you so much. I can see one question. I don't know, Prof, will you take it? Prof?
Okay, I was just reading the question. Yeah, can preeclampsia be prevented in subsequent pregnancies? Yes, it can be. I wouldn't be able to give figures, but if you have a patient, a woman who has previously had hypertensive disease, then in a subsequent pregnancy, you would do all the preventive measures that have been talked about, which is starting her on low dose aspirin, putting her on calcium, and of course monitoring her very closely for high blood pressure. And if it does come up, then you would start treatment very early. So you may prevent it completely, or you may detect it early. So either of those things can happen. Can prolonged use of aspirin cause premature closure? We normally stop the aspirin at about 36 weeks. And most likely by that time, we will have started screening for delivery. Risk of preeclampsia continuing as hypertension after delivery. Yes, you do have, you will not be able to predict that. And I don't think I have the figures offhand unless Dr. Ajabo has, but there's always that risk. And that is why you must continue monitoring these women up to 12 weeks post-delivery to confirm that the blood pressure is back to normal. And if it doesn't, then of course you will label her as chronic hypertension. Okay, so I think we've hit the time of 8 o'clock, and I would also like to thank all of you for this initiative you've come up with of these presentations and the grand round. Welcome.
Thank you very much, Prof.
Go ahead.
Thank you as well, Dr. Ajabo, for taking your time to assist us with this case. I've seen quite a few number of registrars who have also joined us. Thank you as well. Maybe just one last question before we close. Someone is asking maybe if you have any comments regarding the presentation in terms of a few comments on how maybe history and physical exam, if you have any comments on that before you close, either Prof or Dr. Ajabo.
So you said with regards to presentation, what to look out for?
Yeah.
Yes. So I'd say symptoms of preeclampsia can mimic symptoms of normal pregnancy, especially if you're looking for edema, you'll just go wrong. If you're looking for headache, they may have headache here and there, and maybe it's even headache of hypotension. So that's why it's easy to miss out on it. The main thing to do is BP monitoring regularly. That's why we screen these women at every visit, and we just check their BPs. It's a basic thing, and that's how we know it. Patients could always be told about the danger signs or the symptoms that we know now as preeclampsia, of headache, of epigastric pain, of the blurry vision. Some of them can even come with just reduced fetal movements, only to see a BP of 160, of 180. So there is no clear way of knowing, but when they come to you, make sure to ask for all those symptoms that you know and do the BPs. Listen to the baby, do your scans, at least 3-4 of them in the pregnancy. I don't know if I've answered.
Yeah, I think that was quite extensive. Thank you very much. Inshallah, next week we'll have year 6 presenting a case from the IMED department on Monday. So Brother Ogle and Fatma Rashid will be in charge of that. Otherwise, thank you everyone for joining. I think we'll close at this point. If Dulkifli is in the meeting, can close for us with that.
Alhamdulillah. على كل حال. I think we've reached the last part of the presentation. Inshallah, I'll just make a quick dua, inshallah. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alamin Ar-Rahmanir Rahim. Maliki Yawmiddin. إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين. اللهم لا سهل ما جعلته سهلا وأنت تجعل الحزن إذا جئت سهلا فاجعل الأمور سهلا وبذلك التوفيق إن شاء الله. close إن شاء الله.
Shukran very much. Thank you everyone for joining. Have a blessed night.